I just want to emphasize certain points why I prefer to do single stage in most of my cases. And I also want to emphasize that how you can use these technical tips to solve this problem in a single stage. So not only instability, persistent pain, diminished range of movement, and any outcome which is not consistent with the expectation is considered to be a failure. There are so many factors that you have to look into when you are dealing with the revision scenario. And one important thing is whether you're going to decide do this in a single or a double stage. I prefer a single stage because with a systematic approach, planning and proper execution, up to 90% of the cases can be addressed in a single stage. Two surgeries 4 to 6 months apart can have a huge economic impact on our patients, and for athletes it will cost them an entire season away from playing sports. So if you can do a procedure in a single stage, I think it will be beneficial to the patient from every point of view. And this is one study which I could find, which compared 3 studies which had a series of 2-stage revision patients and 21 studies which reported on the outcomes of single-stage revisions. It is not a randomized comparative study, but still overall there are comparable results in both the series. But the clinical failure rate was twice as high in the single-stage patients when compared to double stage. So double stage, in this study has shown less failure rates. But patients who require these 2 procedures, 2 approaches may be belonging to entirely different subsets. 2-stage revision is absolutely indicated when you have a stiff joint where you have to release the stiffness and do a revision, and you have a strong suspicion of infection, and whenever the tunnel widening is more than 15 millimeter. Some relative indications are when you're planning a complex procedure, combined procedure, when you have to correct a bony deformity or tunnel deformity in the intermediate range of 10 to 14 millimeter, one may choose to go for a 2-stage procedure. There are steps in performing a successful single-stage revision. Identify the key factor why the ACL failed along with additional missed lesions. You have to have a good graft choice, good tunnel management strategy, good fixation strategy. Whatever graft you use, you have to protect the graft by adding procedures like an extra-articular LET procedure, medial reconstruction, PLC, and osteotomies as required, and rehabilitation should be non-aggressive. There are many different causes of failure. Technical reasons could be found in up to 70% of the cases, along with trauma in more than 35%. Standard investigations should be performed, most importantly 3D CT to know the tunnel widening, and X-rays to know the slope and alignment issues in sagittal and coronal planes. Graft choice depends on what graft has been used previously. BTB is my graft of choice, along with quads being number 2 choice. Sometimes we can use peroneus longus and hamstrings in non-athletic patients. Pre-existing implants need not be removed routinely if they can be bypassed. Bioscrews can be drilled through. Even titanium screws are soft. If you are using a strong steel drill, you can drill through the titanium screws as well, according to some studies. Let's go to the femoral tunnel management. You can have 3 scenarios. The non-anatomic tunnels were very widely apart, very easy to revise. Most difficult is a partial anatomic tunnel, which may result in an overlapping tunnel, and anatomical tunnels which are widened. So this is an example of a non-anatomical wide apart tunnel. The femoral tunnel has been made somewhere else. Luckily, the tibial tunnel could be reused here. And you can see the femoral tunnel is far apart. We are able to make a new tunnel right at the back. And in this case, we used a bone quadriceps tendon graft. And it's very important that you look into the tibial tunnel all around to see whether you made a tunnel coalescence. In this case, there was no tunnel merging. And in this case, along with this revision, we can also see we have taken a strip of IT band to add a LET procedure in this patient. But second scenario is where you have a non-anatomical tunnel, but they are too close. And here, if you are using the same tunnel drilling technique, you can have a very thin wall or you can break the wall. One way of doing is you use a different tunnel technique, maybe an outside-in technique or a transportal technique if another technique has been used previously. Or you just fill the existing tunnel with a bioscrew and drill a new tunnel so that you won't violate the existing tunnel. So this is a filling screw technique which you can use. This is an example of a similar procedure like this one. And this is an example of a partial anatomic tunnel which can result in an overlapping tunnel. As you can see, this is just a few millimeters from the intended anatomical position. And hamstring graft has been used. Here I am doing an eccentric tunnel. I just use a posterior drill guide, and I am just shifting the tunnel posteriorly, so we have an elliptical tunnel right now. We are using a BTB bone graft. The tendon part is posterior, and by using the screw anterior, we have been able to posteriorize the graft to the desired location. And also it's very important to address any concomitant lesions. Here this patient had a lateral root avulsion, lateral meniscus posterior root avulsion, which has been addressed as well. And then next we come to the situation of anatomic tunnel, which is not widened. It's very simple to revise, but you have to think why a perfectly done ACL fails. Otherwise, you'll be doing the same mistake once again. Was it a trauma? Was there any misrelation? All these things have to be identified and addressed. The final situation is an anatomic tunnel which is widened. So here we have a large tunnel, but you want to put a screw graft in a position and also fill the other part of the tunnel with something else. So you can use what is known as a positioning screw. A large screw can be used to push the graft to the desired position. It's very important to use a notcher in the desired position so that the graft screw doesn't spin around the graft. So notching is very important if you want to push the graft to one side and keep the screw in a different level. And also you can use a graft like BTB to create a square peg in a round hole. And one important technique is you can flip the bone part of the quadriceps tendon or BTB to create a large femoral plug. Up to 14 to 15 millimeter of plug can be produced by flipping the bone plug over the graft and suturing like this. So this is an important technique when you are facing a tunnel with a very large opening. And if you can't use any femoral tunnels at all, you can take the graft behind the femur and you can use over-the-top fixation so that you can avoid all the messy femoral situations all along. This is the last resort for managing the messy femoral tunnel situation here. Coming to the tibial tunnel, it could be challenging because we have a soft bone, we have an oval opening at the joint. It's very difficult to make new tunnel unless the old tunnel is 10 millimeter away, and tunnels are often overlapping. An anterior tibial can be repositioned by doing an eccentric reaming and keeping the screw anterior. And a posterior tibial tunnel, if it's more than 10 millimeter, can be eccentrically, you can create a new tunnel, or you can eccentrically ream and use a large tibial bone plug to fill the tunnel and rotate it so the graft lies anterior. And I use LET in all the cases and address collateral laxities. I believe that LET in revision scenario protects the graft. As you can see here, there's a revision scenario, BTB revision has been done, but still the pivot shift is persisting, which disappeared after a lateral reconstruction. The rehab protocol should be non-aggressive. To conclude, two-stage revision has a role, but in a very small proportion of cases, maybe a different subset of people need it. With careful attention to detail, planning and execution, you will be able to manage most of the situations with a single-stage approach, which will save time and money for the patient. But it's very important to choose where not to do a single stage. Thank you very much.